Hello, and welcome to today's health webinar. This episode is brought to you by our friends at ImageTrend. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Julie Cardy.
Hi, everyone. Welcome to our webinar today. I have the great pleasure of being your host and your moderator today. So today we're here to talk about emergency medical services data, or EMS data, as we will refer to it today, and how this pre-hospital data can improve patient care, can improve operations, and improve market share as well. So every year in the US, there are 70 million EMS activations, and only about 3% of that pre-hospital data is truly connected and interoperable with hospitals. So we're making critical care decisions with incomplete information and often too late as well. Today's conversation is about changing that. As mentioned, we welcome questions. Please use the Q&A feature, and at the end of the webinar, we'll be sure to leave time and get through as many of these questions as possible. And with that, I would love to introduce our panelists. I'm really excited that we have a great panel today of physicians, of healthcare executives, and innovators in the healthcare space. So, Joe, I'd love to invite you to introduce yourself.
Thank you, Julie. I'm really looking forward to this discussion as well. My name is Joe Graw. I'm the Chief Growth Officer at ImageTrend. And really, what I've spent the last nearly 25 years on is working in the intersection of EMS, pre-hospital, hospital, and data. And so one of the things that we're really excited about is what Julie had mentioned early on. We've been doing a lot of advocacy for interoperability. So just giving the audience kind of some cues to think about as we see more of this spread across the United States. So good to be here. Looking forward to the conversation.
Great to have you. Thank you, Joe. I'd love Hannah to introduce himself.
Yes, hi. Thank you for having me. Really excited about this conversation. I'm Hana Ida. I'm an emergency physician in Houston, but also Chief Medical Officer at Tele 911, where we actually work directly with EMS agencies across multiple states to support real-time clinical decision-making in the field. My perspective sits right at the intersection of pre-hospital care and the ER. So I see firsthand what happens when critical information doesn't show up when it's actually needed. I'm also a faculty member at Texas Engineering Medical School. I'm also an engineer. So there's a lot of innovation twists in this pre-hospital care. So excited to be here. Thank you so much.
Thank you, Hannah. Lots of hats. And last but not least, I'd love Kevin to introduce himself.
Hi, everyone. Thanks for having me. My name is Kevin Munjal. I'm the Chief Medical Officer at Care2U. Care2U provides emergency care in the home as well as hospital-level care in the home. We're here in the New York region. In addition to that, I spent a lot of my career in academia and I'm helping lead a New York City regional effort to integrate EMS data into the hospitals through a centralized mechanism through the regional HIE. We do that under the banner of the New York Mobile Integrated Healthcare Association. So pleasure to be here and look forward to the conversation.
Thank you, Kevin. Thank you all for being here. I'm really excited for today's conversation. So we can jump right in. I want to spend some time really understanding the current state and what's broken and why we need to have this conversation today. So Hannah, I might start with you as an ER doc. Can you kind of paint a picture for us? What does the disconnected data actually look like in an ER shift today?
Yeah, so we don't have a data shortage. We have a timing and accessibility problem. So what we usually get is a snapshot. We don't get a trajectory. We don't have a lot of ideas of what the vitals are improving or the crashing. What is the scene context? Was a patient found down? What were the living conditions? What was the med compliance? That rarely makes it in. Sometimes we don't even see the medic handoffs. They are just kind of dropped off in the ER and we don't have any documentation. It's really hard to get a history from the patient themselves. And we want to see why EMS made those certain decisions. They are clinicians in the field. They are our partners in the field. And what they were worried about and what nuances got lost. So, and we're all also alternative pathways were they actually considered? Was was this a borderline patient for non-transport? So, how the disconnected data looks like? It looks like making high-risk decisions off a verbal handoff and partial PCRs, and a patient who may or may not be a reliable historian. And meanwhile, the most valuable data, the first 20 minutes of care, is either delayed, buried, or never even seen. So not from the field to the ER, from the ER to the hospital, from the hospital to the outpatient, and completely outside the system, we divert care. So EMS is the front door of healthcare, but it's at least digitally connected part of it.
Okay, and it makes your docs and the nurse's job even harder. And it sounds like sometimes that information comes in late, so the HCPs need to make decisions, and maybe sometimes contradicting information might come in after those decisions. Is that right?
Yeah, absolutely. It's
Okay.
really hard to have the lens of the first responder on scene, and it's really difficult to actually translate that information into the ER context. Things change a lot, and having that accurate data helps the patients get deliverable care faster.
Well, thank you. You know, from your perspective, where in the system does that data actually break down today? As Hannah kind of mentioned, there's a lot of places where we need to transmit that data, and where is it getting stuck?
Yeah, from a technical perspective, it's interesting to look at this. From my perspective, it's more at a macro level, but there's a couple of components that are important, and Hannah hit on this. There's missing data, there's delayed data, and then there's unusable data. And when you combine all of those things together, it makes it very difficult for the receiving facility and the physicians in the emergency department to make informed decisions based on that critical data source pre-hospital. So when I talk about missing data, a lot of it just never makes it into the hospital workflows, right? And one of the things that I love to talk about anytime I get an opportunity is pre-hospital uses a standard called NEMSIS, which is the National Emergency Medical Service Information System. And the beauty of the standard is it has 100% adoption across every EMS and fire department in the field. So what that translates into is a structured data set that can be centralized and moved across the care continuum using standards. So where I don't necessarily say that there's a breakdown or something's broken, I look at it as an opportunity to say that there is a data standard that exists pre-hospital that can be translated into an HL7 ADT message, for example, that can stream as the patient moves across the different care continuum. So that I think is the biggest opportunity, and in many cases when we look at interoperability, and Hannah hit this as well, the data is not accessible easily, it's not usable easily, and in many cases it comes in the form of a PDF, or a fax, well after the patient has been seen and clinical decisions have been made. And then finally, I'll just, net it out. I think that EMS does a really good job on the assessment side, right, for high acuity, low acuity patients across the continuum, but only a fraction of it influences the care in the moment that it matters most. So that's the opportunity, I think, from a healthcare perspective, to connect the dots and improve the experience for the patient.
Awesome. Well, it's really great to hear that that data is available and structured, and that it's 100% adopted. So let's get into that later on and see how we can really make the most of that opportunity. And Joe, going to press you here in terms of, we mentioned like missing data, delayed data, unusable data. Is there one that's a greater problem than the rest, or that shows up more often than the rest, or is it just a cocktail of all of these issues that we see quite regularly?
That's a good question, and My perspective is there's a lot of missing data and unusable data, and missing data in the sense that it's not being mapped properly into the hospital or the EHR ecosystem and served up readily to make decisions. And also, like Hannah mentioned, we're not lacking data. There is a lot of data that's moving around. I think in ensuring that it's properly translated and served up when it's needed most is the most critical aspect of it. So,
Thanks, Joe. That's good to know. Um, and Kevin, interested in your perspective, how does this lack of context affect the care continuity after the ED or even outside the ED entirely?
Yeah, that's a great question. So, and ha Hannah kind of alluded to it a little bit. The care that's provided by EMS is essential. But first of all, as many people on this call might know, only about 70% of patients seen by EMS, probably even less, actually end up in the emergency department. There's a lot of cases where they're not transported, something else transpires. And so, for the cases that do go to the ED, it's probably not every case, but beyond the emergency physicians that receive that patient in the ER, there's probably downstream physicians, the internal medicine department, the ICU, the infectious disease, who are the great investigators in healthcare, who want to go back to the scene and figure out what was actually there. And when that data is missing, that's a huge gap in the way we provide care. But what I think is really interesting is I think there's a lot to be gained when EMS data starts to become available, not just in this one-to-one model between EMS and the hospital on this one episode of care. When you start to look at it on a population health level, I think there's a lot of interesting data that can be received there. And then when I've been advocating to try to get EMS data integrated into the regional health information exchange, what turned out to be the biggest selling point wasn't so much about how we can improve electronic record communication for the hospitals. It was actually like, hey, maybe the primary care doctors can actually get access to this. Maybe they can find out that their patient was seen 3 times in the last month for a fall, a lift assist. Maybe they can
Mhm.
find out that they keep RMAing from their hypoglycemic episode or their asthma attack. And I think that became really powerful and became a motivating factor in our region to really push this forward among some of those that were a little harder to convince.
Hmm. Thank you. I think that's really important context. And then particularly in areas like New York City where folks are accessing so many different points of care to actually bring that all together. Um, it's just amazing. Okay. I'd love to dig into that a little bit. Like when we talk about connected EMS data in practical terms, like Kevin, you've just kind of uh, shared a picture, a snapshot of what that could look like. Joe, when ImageTrend talks about connected EMS data, what does that look like in practice, not just theory?
sure. Um, it from our perspective, the mission is to move the data in advance of the patient. So when you're thinking about a clinician pre-hospital that's charting, we want to, as soon as they select that destination that they're transporting the patient to, open up a stream of data, but only the data that is relevant to that team that's going to take over care for the patient the second that they hit the ED doors. So there's a preparation element that I think is very important, and we have to also understand that that data can move very quickly. I think Kevin had mentioned this too. There's a lot of patients that are seen pre-hospital that are not transported. We
Mm,
looked in the data set, and
70%.
if you look at the 70 million or so activations annually in the United States, we find, if we look at a specific carve out for, let's say, behavioral health related, could represent around 8 million of those activations. Around 25% of them result in a treatment in a non-transport. So for the primary care providers and the clinicians and the care teams, how do we get that data connected to the longitudinal event for that patient as well? Those are really important markers for us. And I also think that once we get the use cases out there, we're starting to see more and more adoption. And I also go back to technology is not the limiting factor here. I think it's education and awareness that the data sets exist and that you can create data harmonization across the continuum of care using different platforms.
Thank you, Joe. It's really great to hear that. Hannah, how does earlier access to this EMS data change decision making in real time? You spoke to us earlier about like when it's not there, how it's affected, and Joe just spoke about getting it there before the patient. Can you now talk us through like how that makes the clinicians and the nurse practitioners' lives easier?
Yeah. So, I mean, interoperability isn't about like sharing more data. It's about sharing the right data, right?
Mm-hmm.
Early enough to change a decision. So if I see a pre-hospital EKG, which ImageTrend and a lot of the EMS agencies have phenomenally done well in transmitting that electronically, I can obviously activate a cath lab before arrival. Now, these are the patients that need transport, two different buckets, the ones that actually need transport and the ones that are low acuity that, like Joe alluded to, that really don't need transport. And in the right social context with low acuity, if I see stable vital signs, normal exams in a social context, I may not send that patient to the ER at all.
Mm-hmm.
And then, for example, another one, sepsis, trending the data early on. And if there's an early suspicion, and how would you change your antibiotics timing and disposition immediately? So early enough means the patient, before the patient hits the ER. So the earlier it is, before they hit the ER, not when they're already in the patient bed.
Mm-hmm.
And I think, like I said, it's the correct data. And the EMS is on the scene. They have that already. It's just hard transmitting that information. And like Dr. Mundell said, like in a HIE, like I don't see the EPCR a lot of times, right? And sharing that data also with a primary care doctor to see, hey, this guy activated 911 3 times. Why? Maybe they didn't get their dialysis. Maybe they had transportation issue. Maybe they had a social issue. So there's a lot of use cases that we can actually say, hey, we can actually prevent this and reduce unnecessary transport, not by guessing, but also by making physician level decisions earlier with better context.
Right. It sounds like initially, one would think maybe the goal is better ED prep, but actually it seems like potentially the goal is actually reduced ED visits altogether.
Right, right. And in our platform, for example, we bring the physician, the ER physician, 24/7 in the patient's home when it was activated by a field medic in the field downstream. So we actually see the whole context. I mean, it can be very chaotic for an EMS agency. Like they come into a house and it can be very hard to actually extract the necessary and pertinent information as to why the patient called 911 in the first place. And they have discharge documentations from like random hospitals. Medications are everywhere, right? And medics are writing on the glove what they're on and their vital signs. So it's very challenging for the field provider, I must say. But I think it's there, the data is there, and translating that and communicating that with the receiving hospital, or maybe not even sending to the hospital, but having the physician on scene, video wise.
Okay. It sounds like the foundations are there. It's about optimizing it now.
Exactly.
Kevin, you mentioned earlier that it can prevent unnecessary transport, so up to 70%, which is amazing. And how does this change where patients actually go? I guess there would have been a traditional kind of pathway before that many patients go straight to the ED. Now, with interoperable data, can you kind of paint a picture as to the different places patients go, or if more and more of them are staying at home?
Yeah, absolutely. And for clarity, so I think Joe mentioned 25% of behavioral health patients. I think in some studies it's anywhere between 60 and 80%, depending on your EMS system. In today's model, without all the enhancements we're discussing in terms of data transmission, payment reform, all those things, there's already between 20 and 40% that are not being transported. So that includes patients who refuse transport or otherwise, there's other reasons why they might not be transported. I think the opportunity, is tremendous in terms of, going further, once we have interoperability of data and getting the right data to the right place allows you to get the right patient to the right place. And what Hannah's team is doing in terms of actually interacting with the 911 system and bringing the physician into the home is tremendous, at tremendous value. We call that treatment in place. There is the idea of alternative destinations as well. Can they go to an urgent care center? Can they go to some other location? A lot of those programs are, they're challenged for multiple reasons. And so we're not going to address all of them, but one of those reasons, right, is just like, can you comfortably, have you need a couple of things operationally, right? You need to make sure that we know that clinically they're okay to go to that location. We need to know operationally really quickly, do we have a good algorithm as to where they can go? Can we discriminate by insurance? Or that's not the right word. Can we target them to where they're in network so I can actually save the health system and others and the patient, save them money? All right, and then can we and then just all the complexities of geography and those things. So alternative destination is a really nice option. The other thing I would bring to the table that probably is a little bit less discussed is the treat and refer option, right? So it's a branch off of treatment in place, but even if the EMS physician is not necessarily involved in that visit, can EMS triage patients to outpatient locations that they would then get to in the subsequent days? Can we get them to a care navigation service? One thing that we're discussing with some EMS entities here in New York is, if a patient refuses transport to the hospital, but you're worried about them as a medic, can you actually, connect them to options in the community, such as Care to You or other kind of healthcare entities that can provide high acuity care in the home, right? And then if you were to do that, it's so much better if you're doing it with data actually flowing from what actually happened in that EMS visit. Can we get that data to the HIE? Can we get that data directly to the referring entity? Can it be as easily I can't speak for Joe. I'm not sure how easy it is, but can you push a button and send the data exactly where you need it to go? That would be amazing.
That's great. Thanks, Kevin, for painting that picture. Joe, would you like to react to that?
Yeah, I think that's where the opportunity is. One of the things that we're spending a lot of time monitoring very closely is the ACA subsidies expiring and the dramatic increase in premiums for insurance coverage. We've heard numbers, between 5 and 8 million people may not be able to afford insurance coverage, right? As 25 calendar year closed. So as we go into 26, we're already seeing signals of population segments that are using 911 for their primary care now, right? So back to the treatment and release, or the treatment and refer, or the treatment in place. As a healthcare system, we have to start looking at those signals as well. And I'll mention Rural Health Transformation Fund for those of you on the call. If you're not tracking on it, I would encourage you to look at that. Every state got a significant amount of money. I want to say the total was 50 billion over 5 years. Every state, like I said, got a carve out. And the idea is to transform healthcare, right? And look at the way that healthcare is delivered. To Kevin's point, to Hannah's point as well, in many cases, for those lower acuity type responses that might be using emergency resources now, can we use the signals in the data longitudinally to create marker or a probability for that patient to be enrolled in a proactive care strategy? And will that proactive care strategy result in something like a treatment in place? And knowing that there could perhaps be sustainability for a program like that over the next 5 years, it's very exciting to see that. And again, the high acuity, low occurrence patients are incredibly important, and it's important that EDs are prepared to handle and treat them and care for them. The lower acuity types that are making their way into the emergency department now, can we look at the data again and create more intelligent routing and care delivery for them? I would say that the data is there to tell the story. To Kevin's point, we're still working, I think, on clicking that button to make sure that we get the data to the right place at the right time for the right reason. So hopefully that helps clarify some of the things that we're thinking about.
That's really helpful. Thank you, Jill. It's great to kind of see this mapped out in practical terms. I would love to kind of double click on some success stories before we dive into the implementation, because it sounds like there is a lot there, the opportunities there, and let's talk about clicking that button or what we need to do before clicking that button in a couple minutes. But before that, I just want to dig into the early impact you guys are seeing or the early success stories you're seeing. So I was wondering, can each of you please share a real world example, either from an individual patient perspective or an individual kind of operation or system perspective, on how better EMS data changed the outcome for that patient or for that system? Hannah, I'll start with you.
Yeah, absolutely. I mean, that's our bread and butter. It's really when an astute EMS field provider recognizes a low acuity patient, gives me all the data, gives me blood pressure, vitals, all the vital signs, a glucose, sometimes point of care testing, and oxygen, sometimes an EKG, and has that data, and then actually can screenshot their medications, and we'll get 911 calls 24/7 of an elderly patient that their blood pressure was high and they thought they needed to go to the hospital. Or there was a young low acuity patient that had chest pain, but it was really from a cough and bronchitis, or some other scenarios. There's many use cases, but once we got that data in real time, and we actually saw the patient real time, and we're able to divert the patient, and the patients love it because they not only get to see a doctor, the doctor sees all the data. I get a physical exam from the field medic on the scene. We were successfully able to release the medics from the scene to actually go into more acute care to more sick patients. And then and also is follow-up, right? So the patients love getting a phone call the next day to follow up on them. So this is something it's available, right? So patients love clicking that 911 button. And it's 2026, so we can actually deliver care at the home, and like Dr. Munjal is doing already. So why not connect those dots with all the health tech companies that are out there?
Makes sense. And it's very encouraging to hear this happening. And Hannah, maybe to double click on that, you mentioned earlier kind of more serious cases like sepsis, like heart attack. I guess you've seen specific examples where this data being connected has led to probably lives being saved because they were able to enter that ER quickly, get an ID consultant very quickly compared to showing up in the ER, showing up somewhere without that connectivity.
Yeah, absolutely. So one real case that I had was a patient presenting with severe anxiety. There was a language barrier. And once we got a translator on the phone, and the medic astutely was saying, I needed to call you because I wasn't sure how to actually take this patient. I don't know what pathway to go down because I really couldn't get a history. And after we were able to calm the patient down, the husband was there. She was having a stroke. She had left-sided weakness. We were able to activate TPA in the field, streptokinase rather, and the medic, the patient, the family, really, it's not only it's physical data, it's like clinical data, right? And another use case is when patients have had ST elevated myocardial infarctions, where the patient was having chest pain and the EKG, first one was okay, and then we were able to repeat the EKG, and then they had an obvious ST elevated MI. So, and these are patients that don't want to, like, they're calling us because they're against medical. They don't want to go to the hospital. They don't think they need to go. But once we got the data, and then once we show the data to the patient is part of the equation, right? It's not just medic and clinician, right? Or medic and actually receiving hospital. The patient's very part of the whole conversation. They're very intelligent. They know what's going on, and once we share that data, not only with the medic, not only with the receiving hospital, but the patient understands and realize that there is a life-threatening condition going on.
Thank you, Hannah. I think that's really excellent to hear these examples. And maybe to double click there, you've started kind of portraying this, but what does it actually feel like for the patient when this system works well compared to when there's zero interoperability between these systems?
Yeah, so sometimes the patients don't realize that they can receive care at home. They don't realize that a prescription can be electronically sent, that I can actually talk to, or even the field medics. They are now they have transformed in the last 20 years. They went from just transporting patients to actually being providers, to actually delivering care in the field, to actually give IV fluids, IV anti-nausea medications, and releasing them in the field. The patients absolutely love having that care. And I think the care at home model has really grown exponentially, even post-COVID. So patients thought they had an emergency, field medic intercepted and said, no, we can actually treat you here. We have our own internal protocols for treatment in place. And then some agencies have treatment refer, like Dr. Munjal was saying, or there's other protocols. Hey, I need to get a physician on the other end to actually approve all of this.
Awesome. It's great to hear. And it leans back to what you were saying, Joe, that oftentimes the adoption is about the awareness and education versus any of the systems that are in place. Joe and Kevin, I'd love to hear from you any success stories, either from an individual patient or a system point of view.
Sure. I'll mention at a very high level, we work very closely with EMS and fire departments all over the country. It was a great story of a department in the state of Wisconsin, suburb of Milwaukee, fire department there. And one of the challenges that they had was just overwhelming call volume. And the chiefs and the leadership were just constantly talking about how to manage this volume, right? And it's reactionary and it's episodic. And what they ended up doing was, again, taking that 911 response data episodically and creating a community paramedicine program based upon that. And they simply focused on 3 of their highest utilizers in the community. And these, again, are individuals that are calling 911 and needing care. And in many cases, this department was dispatching emergency ALS level resources to respond and provide that care. And what ended up happening was there's overlapping calls that are constantly happening, right? And if the majority of the responses are lower acuity that you're using all of your emergency resources to take care of, when a true high acuity type call comes in, it can have a major impact on the patient that's being seen and then the outcomes ultimately. So this department enrolled a few of their higher utilizers in this program to see them proactively. And initially, they were not getting reimbursed at all. They painted a very clear picture to their city council that instead of focusing on an ever-growing volume challenge, they flipped the script and started focusing on value and value delivery to the community that they served. And they used those individuals as a talking point to continue to expand their community paramedicine program and also to get some sustainability in terms of revenue to keep the program going. So it's very exciting. And that's just, again, one small case. These things are starting to pop up more and more as education and awareness continues to trickle through the healthcare system. So
Excellent to hear it. Thanks, Joe. Kevin, I'd love your reaction as well.
Sure. Yeah. I mean, I'll quickly echo, I think probably the biggest success stories, I think, between EMS and hospital data integration and collaboration has been in the stroke and, and just, and STEMI kind of pathways. There's a number of companies that have successfully, kind of, been able to bridge that divide and help reduce, yeah, instead of door to balloon times, right? EMS to balloon times for those types of interventions. Echoing kind of what Joe said in terms of the community medicine opportunities, you know, uh, what Hannah's doing in the 911 system is tremendous. Locally, and sort of my experience first at Mount Sinai, where I was a leader of their EMS system for a number of years, and then now at CareU, we've kind of changed the traditional model. We kind of think of 911 as kind of being this, one-stop shop that takes them to the ER. And patients typically call because they maybe can't get a hold of their PCPs. And it's sort of this disjointed model. And we've actually kind of flipped it a little bit, and then we've actually empowered PCPs, primary care doctors, to actually help their patients stay at home, right? So when the primary care doctor gets that phone call, whatever time of day, and it's like, oh, I have shortness of breath, and it's a complicated patient, right? It's really easy. And in the past, all you have was options ED or wait till the morning and see me in the office, right? But we've created this new model where you can actually get an EMS resource, and depending on your local jurisdiction, maybe that can be within the 911 system. But in New York, it was easiest to kind of develop that outside the 911 system, right? For those that don't know on the call, like a huge component of EMS actually is outside of 911. So we actually were able to, at Mount Sinai, we built this program called the Mount Sinai Community Medicine Program. We would respond very quickly with an EMS unit, and they were able to do a handful of things. They were able to keep, I think, 2/3 of patients out of the hospital. And then kind of, the care to you model takes that further. And now we have PAs and NPs as well as paramedics, and they're able to keep, 85, 90% of patients out of the hospital and transition them right into hospital at home. So it's really transformed, how it can all work. So, and the data component, of course, I think we're still working on figuring out the best ways to tie into traditional EMS data there. But we utilize, those EMS providers in the field to make it all work.
Yeah, it's amazing stats there to hear so many people can be kept at home in such a complex system. I'm interested from like an ROI perspective, who actually captures the value? Is it the health system? Is it the payer? Is it the EMS providers? Is it a complex mix of all? I'd love to hear. Kevin, you're smiling, so we'll go to you first.
Yeah, no, it's a fantastic question. So, obviously, the answer is it depends, right? It depends on who's paying the bill, follow the money. But I would say that when we're able to shift care from one of the highest cost settings, which is the hospital, to a lower cost setting, which is the home, we're able to dramatically save dollars. Now, who that accrues to the most? I would say a significant amount of that accrues to the payers. However, there is an unbelievable improvement in the quality and patient experience for that patient themselves and the families. And think about the expense of, going to the hospital, having to take time off of work and all those kinds of things. When now that they're in the home, your existing home care situation, the aids that you have from an agency don't get canceled because you went to the hospital. The physical therapy program you have doesn't get canceled to be reset up. So there's all this, honestly, administrative and just sort of
Mhm.
time that is saved for the family when you're able to bring that high acuity care into the home.
Okay, thanks, Kevin. Maybe Joe, I'll ask you from a health system perspective, are there any metrics that surprise you in terms of ROI or gains that the health system made? And I'd also be interested for new health systems thinking of bringing this on. How do they make a business case for this? How have you seen more often than
Mhm.
not?
Yeah, I think very very quickly what we start to see when this is implemented is it's foundational, and I think for the folks on the call that are looking at this and wondering what questions to ask, my suggestion would be to start with a simple use case and not try to solve everything right off the bat. What we found in working with health systems that are successful with this is it's very iterative, and we continue to build on what interoperability means. So, for example, if we need to focus on streaming data to receiving EDs for high acuity patients, that's a great use case. We will start to measure the success and impact of that, and then move on to the next one and to the next one. And what we've started to see again, when you look at ROI, again, I should say my lens is on the pre-hospital side, so it is very helpful to ensure that emergency resources are available to respond to high acuity types of responses, which is truly what the 911 emergency response system was built for. It has kind of morphed into a safety net for all communities now, where you call 911 and you expect someone to come in and take care of you regardless of maybe what the acuity level is. So within healthcare systems, treatment in place, like has been mentioned several times here, but also routing to the right locations within a healthcare ecosystem. It's not always the front door of the emergency department. There are urgent care clinics, there's freestanding emergency departments, there's alternative locations where care can be delivered more timely, that ultimately provides more value to the patient, and then also the broader healthcare system, that we're really trying to protect those emergency resources to respond to emergencies. So
Makes sense. It frees them up to deal with those high acuity cases. I'm interested, so in the value capture, we've seen that across health systems, and Kevin, you've mentioned that it's complex and that there's a lot of value and a lot of opportunity to be gained. I'm wondering, are you seeing that payers and health systems and the different entities that serve to gain from this truly interoperable system, are they thinking of it in a very strategic way and using this EMS data as a lever for population health, for their plan growth, for the health system growth? Um, would love to hear your perspective on it. Maybe Hannah, I'll start with you if you have a perspective on it.
Yeah, absolutely. It's a great question. I think a necessary stakeholder at the table are the payers. I think a lot of times payers don't know that there's mobile integrated health and community paramedicine that deliver care. I don't think they know, a lot of them, that EMS agencies have morphed into this comprehensive care model where they can actually go to the patient's home, prevent an emergency, making sure they get their medications on time, do frequent, and this is different from home health, right? And that can actually make sure they get their oxygen. They would see the discharge summaries when they first got discharged. And once payers get that information, they're astonished. And I know one payer, I was chatting with the CMO, they actually got into the MIH space. They actually contracted with a transport agency. They are the point of contact for when a patient has a question. The payer has now become the provider. So there's a lot of payer providers out there, Kaiser, right? Kelsey Siebold here in Houston, Texas. And some of the providers, Optum, for example, are getting involved into the patient's care, and they are actually becoming an integrated piece on the patient care delivery because they have that data and they have physicians on their team and they have mobile integrated health on their team. So, and I think it's catching speed, but not quick enough, because everything is out there. MIH is out there, tech is out there, AI is out there. It's all about connecting the pieces.
Thank you, Hannah. Kevin, Joe, do you have a perspective on this strategic element of this EMS?
Well, I'll say that I think there are a number of payers who are thinking strategically about, how do they move dollars, from the hospital to the home, and can the EMS agencies and other kinds of community care providers be a part of that? But do I think it's enough? No, I think there's a lot more opportunity out there. So certainly, if there's anyone listening, I hope that they're recognizing that there's a really untapped potential for this. And I think that uh, EMS in particular, I think that, there needs to be, this transition to value that Joe mentioned. It needs to be rewarded, and we need to figure out the payment mechanism so that EMS agencies, when they look at their book of business, which is, for most, this can be a 911 component, non-911 component, right? And increasingly things that blur the lines that are sort of mobile integrated healthcare, got to find a way to make those service lines all stand up and be able to make sure that we're staffed appropriately to provide the emergency care. And so part of that problem is when you're only paying for transportation, right? That's 60% of your cases in a small rural area. That's not a large number of things. You just can't be staffed to be prepared. And so, in fact, it's a win-win-win, probably could quadruple win, right? If we're able to figure out finances for EMS agencies to make sure that they're whole, they can do better emergency care, they can do better preventative and population health care, they can do hospital at home, and they can do better, be faster, more reliable intrafacility transport, which the hospitals get angry when they can't get an ambulance to take their patient out of the ER or out of the hospital, right? So and the patient gets a better experience, right? So if there's 5 wins if we just figure out how to repurpose the dollars from transportation to value in EMS.
Thank you, Kevin. I know there's lots of questions in the chat, so I have one or two more, and then we'll move to Q&A. So, in terms of what's holding us back, we've kind of alluded to this a number of times throughout the course of this panel, but I really want to just double click and make sure we're clear. So the data is there, the opportunity is there, the technology is there. It sounds like, Joe, you've alluded to a couple of policies and transformation acts which are there as well, which is amazing because oftentimes that's not the case. So what is that one thing that's holding us back? So Kevin, you've mentioned that kind of flow of money. Anything else that's holding us back? Because as we've heard, the adoption is still pretty poor given the amazing stats, the amazing success stories. So I'd be interested to hear from each of you, what is holding us back, and if there's one thing we could change today to really start to scale this.
I could go first, Julie, if that's okay. I
Yes,
think
please.
it is as simple as there is a perception of complexity across
Okay.
these care points and the data moving. And what we want to continue to advocate for and educate whenever we have an opportunity is to leverage standards that are already in place to capture this data and to transmit it to whatever endpoint within the healthcare system that it needs to go to. That I think is a very important factor as we've spent more time working with the hospital side. We oftentimes do hear that it's complicated, and how do we take that unstructured data that's being collected outside of the four walls of our hospital and normalize it and move it into the EHR? So I think again, that is a perception that we are working on as well, just to paint a picture of how the data can move very easily, technically across those different segments. I think we also have to be very thoughtful around security. And I think that this is an area where we should all double click on, because as data is collected, we want to make sure that as it's transmitted, as it lands in different endpoints, there's full accountability and auditing across the data continuum, and that data is encrypted in transit and at rest where it lands. So just making sure that we can get out in front of that topic as well, I think is very important, and it resonates with healthcare IT, which are rightfully concerned anytime you have a conversation about interoperability. So.
Absolutely. That's interesting to hear you say that, because over the course of this conversation, both Kevin and Hannah have outlined success stories in insanely complex systems, places like New York and other cities in the US where there's a lot of different options available. And so that's great to hear. Hannah, anything to add from your perspective? What's the one thing holding us back scaling this?
So I think it's backwards data, right? Or it's data. Collecting data as a field provider, as a medic, is very difficult. But I wish the hospital shared data with the medic, right? Like at the point of care. Like they got access to their discharge summary. They know exactly what happened to the patient. They were a post-transplant patient with a left ventricular assist device when the patient activated 911, and they live in another state. For example, we see a lot of that at Houston Methodist Hospital or at MD Anderson Cancer Center, who a patient had bone marrow transplant, for example, and they spiked a fever. And it would be wonderful if the field provider had that information, because the patient may not be able, I just had a transplant. Well, what transplant did you have? Some patient says, well, I had my left, or I had a kidney, or I had a pancreas scan, or I think I had both. But it would be wonderful if that information was available for the medics to access, because that will help them deliver care in the field and also transmit that information back to a different hospital if they're in another state, or or a patient that's picked up from a nursing home. So a lot of data is missing. Also, it's there. It's just we just need to extract it from the care that the patients received already before a field medic was actually responded.
Joe and team are working on those buttons, right? Well, thank you so much. And Kevin, I know you gave your perspectives before that kind of flow of the money. Anything else you'd like to add before we jump into the questions?
No, I think you posed a really interesting question, like what's the one thing that's missing? And I think it's a lot of little things. I think at the end of the day, I think um, we've got to find a way for hospitals and EMS to I guess play nicer in the sandbox, right? Like there's often like these firewalls in between, and how do we I don't know what it takes to overcome that. One thing I've often pointed to is that EMS agencies often don't overlap very well geographically with health systems. So, the incentive to partner with the one EMS agency that makes up 1/20th of your territory and have to have 19 other, workflows, really is a challenge. So to the extent that EMS can regionalize or have regional collaboratives, I think that helps us as an industry better to be better partners with hospitals and payers. Yeah. And the only thing is we've gone 53 minutes in this conversation without saying AI, so I think I should bring that up. I mean, I think there's a lot of opportunity to potentially solve the problems that Hannah is, I think you said that the information's there. I'll just add to it, but the information's not here, right? It's there, it's not here. And AI might be something that we can leverage to kind of bring the relevant information at the point of care for EMS, and then also the relevant point of care to others downstream. So.
Great point, Kevin. I know it will be welcome for a lot of folks that we have spent a moment or two without AI, but absolutely that opens up a huge opportunity as well. I'm eager to get to the questions. I'll jump in to Judson's questions first. Has anyone on the panel discussed having patients' information at the point of care that provides the EMS team FHI or a bundle that can be shared by the patient? Hannah, it sounds like that's quite similar to what you just spoke about. This information can be captured in the EMS PCR, which in turn can be passed on to the ED in real time so that the patient data per event and post-event are available for reporting. So, and Judson has also shared a resource on that. But Hannah, I think, you've just given that example. There's another interesting one. Could new entrants like retail health or tech companies reshape how EMS is used? Do you think there's an opportunity for those untraditional players?
I'll jump in. The short answer is yes. I mean, I think to the extent that they could be, places where EMS could potentially divert, patients that would otherwise go to the ER to those locations. And then, of course, we receive patients from those locations when they get escalated, right? So can we make sure that the information, maybe using the fire example that Judson brought up in his question, can information be handed off to EMS in a nice compact way, whether it's the patient record held in some kind of fire module, or can it be these other entities that may not use traditional EMRs, right? Can they hand off information to us efficiently? I don't know if Joe, if you want, are you guys using the any kind of patient records that you can incorporate?
Yeah, I was gonna chime in on Judson's question as well. There is a treatment use case that was defined, I want to say with TEFCA, under ONC, which is the policy maker side. Care Quality is a national network that hospital systems have used for many years. I want to say it was about maybe 2 or 3 years ago, there was a use case that was carved out for treatment. So what this allows a first responder to do now is they can simply scan a driver's license if they have it, or an identification card, or manually enter the patient's demographic information. And then what will happen is a query will run if they're connected, if they have a network or an internet connection. It will ping that national network, and it will bring back that patient's medical history, the allergies that they have, and then the current medications that they're on. So again, that treatment use case has been very valuable to providers, just serving up a few pieces of really critical information. Judson, the calls are not FHIR enabled yet, at least from my perspective. I could be wrong on that one. Once FHIR segments are available, I believe that treatment query will be able to run much quicker than it does now, because you'll just be querying for those particular segments inside of like a CCDA document. So. And then as far as I think the other question was around tech, or other entrants to the EMS industry, I really think that the data itself tells a story to transforming healthcare. And I think that's what we've all talked about for the last hour. It was interesting, Kevin, that we didn't use AI at all. We didn't say that. And now we've said it 3 or 4 times in the last couple of minutes. But I think connecting that data source to the rest of the healthcare ecosystem, folks that can latch on to that to help tell a story and paint a picture at a population health level are really going to be the ones that transform health delivery in the United States. And I also think that same concept can cascade across the rest of the world, as a matter of fact. So the data source is still largely untapped, is what I'll close with, and we're working hard collectively to connect it.
Excellent. Thanks, Joe. It's a nice sentiment. I'll try and squeeze one more in. EMS services play a critical role in immediate medical assistance to pregnant individuals where labour delivery units receive direct EMS deliveries. Has this created a separate workflow in the build out of your companies, or any challenges? Sounds like nothing specific in terms of dealing with pregnant women in labor.
No. Not on the data capture side. Yeah, again, we're leveraging that NEMSIS standard. We can also include critical care related data points specifically for that use case.
Great.
Thanks, Joe. For us, if a patient is pregnant and she has a pregnancy-related complaint, we are unfortunately unable to treat that patient in place.
Okay.
Right. And it's one of those scenarios where they actually need. However, in a rural setting, I think there could be some value, right? But in the urban setting, it's something that we obviously can't treat right away, like potential miscarriage and so forth.
Okay, thank you for highlighting the differences. I know we're at 1 minute to go, so I don't think we'll fit in another question. I wanted to say thank you to the attendees for attending and for the questions. They're much appreciated. I wanted to also say a huge thank you to Joe, Hannah, and Kevin for your kind of generous insights and knowledge and sharing that with the group. It's very much appreciated. And I want to wish everyone a wonderful afternoon. Thank you again.
Thank you to ImageTrend and to everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Join us in Amsterdam, June 15th to 18th for Health Europe.